Dr. Zelenis sort of alluded to, I think the major topic here is this is going to have to be the Twitter version of the updated mantle cell lymphoma because it's entirely impossible to tell you everything you need to know about mantle cell lymphoma in 20 minutes, okay? So I cannot talk about mantle cell lymphoma without addressing chemotherapy. I think it's actually very critical to do that because I don't think we can understand or conceptualize the role of novel agents without thinking about it as it relates to chemotherapy. So that's how this is. And the take-home message is that in my view, and I think most people's view, the approach to patients with mantle cell lymphoma is very much a personalized approach and is not yet a precision approach, which of course is this hotbed term that I'm happy to say I'm the first to say at this meeting. Okay, so my disclosures, this is the classic NIH slide. I have no disclosures, but I do want to say that the disclosure is I have to introduce my own personal bias when talking about this because what you can be certain of if you stand up and talk about mantle cell lymphoma, the only certainty is that there will be significant disagreement with whatever you say with other people in the room, and that's because it's a difficult disease to study, and many of the decisions we make in the clinic are not necessarily guided by randomized trials or evidence-based medicine. Nonetheless, we have to make these decisions, right? So these are what I consider to be the important questions or the relevant questions today, and I'll break them down like this. Basically, I still believe an important question is when to actually start therapy. So I do want to address that briefly. And the age-old debate of who should get autologous stem cell transplant or what I think of as intensive therapy is still relevant. There's new data to help us think about it, but it's still relevant. But I think it's important to understand where that comes from and how that might be different today. But a newer question that's coming up with data to help us understand this is actually when to stop therapy. So doctors are good at starting, we're poor at stopping. This has been touched on. And so this gets at extended duration of therapy, maintenance therapy, and the like. And so I'll show you some of that data. But what the purpose of this meeting was to think about how novel therapies can be used. In mantle cell lymphoma, of course, they're approved in the relapse setting, but what's really going to move the ball down the field is using them in the upfront setting, and so I'll show you what we have at this point and touch on what I think are the relevant things to think about there. And personal research interest of mine is in the category of molecular monitoring, and I do want to show you some data, or at least some concepts that I think will become relevant in all lymphomas and will apply to mantle cell lymphoma. Okay. So what a few things to think about with regards to mantle cell lymphoma that I think are relevant is that it's not very common. So in distinction to follicular lymphoma and large cell lymphoma, this is only 3 to 4,000 cases a year, which makes it difficult to study. That's why we don't have randomized trials to answer many questions. It's not CLL. We do not have many cases of this. And most of the patients are actually older. So if you look at NHL subtypes, this is the oldest population that we know of. And so many of the data sets that we see are not generalizable to the patients we see. Okay? That's very important. It is incurable, and so what autologous stem cell transplant has proven over and over is that it does not cure the disease. We can say that. And this is what I like to call an alternative fact, that the overall survival is 3 to 5 years. Now, the reason I put this up here is because this is the basis for why people started using autologous stem cell transplant, because the survival was poor when this was sort of first identified in the early 90s. But now it's not the case, and this is a moving target. This is maybe even an underestimate of what the overall survival is. But what you can tell your patients when they're first diagnosed is that their prognosis is clearly improving. Okay? And in my view, I think one way to conceptualize this is many of the discussions that are being had in this disease are very, very similar to the discussions and debates that have been had over myeloma over the last decade. Okay, so these data come from Cornell. And this is a very simple question that was asked, and that is, what happens to your patient if you don't start therapy at the time of diagnosis? Okay, so it had been recognized for many years that there is probably 15, maybe 20% of cases of mantle cell lymphoma that have a very indolent course. In fact, it can look, for the most part, exactly like CLL, both clinically and biologically in many ways. And what they observed is the following. If you just decide that you're not going to treat the patient right away and you get a sense for the pace of their disease, the majority of times you're going to figure out in that first 3 months, yes, they need treatment. Okay. But there are patients that if you don't treat them straight away, they are going to go 1, 5, even longer years before they actually need treatment. And that's important. and you're not harming them. So this is their survival curves, and I wouldn't say that observation improves their survival. I would say that this is something that you aren't harming your patient, to include if you look at when you actually start therapy. So you're not letting the disease get worse with uncontrolled data. So then the question has always been, can we figure out at the time of diagnosis who is not appropriate for observation? I think the simple answer is not really. You can look underneath the microscope and you can identify this group of patients that has the blastoid variant. Those patients probably should not be observed. The other ones, though, it's difficult. And the reason is, despite the myriad papers describing the ways to capture proliferation in the clinic, there really is no clinic-ready way to do that. In my view, the best test is a gene expression profile. This is not available clinically, although it's very biological. The Ki67, which every doctor who treats mantle cell lymphoma will ask you what the Ki67 is, but it's not reproducible. And that means that it depends on what the pathologist sees. Their eye goes to the site of higher staining, and it's difficult. Now, everyone gets it right when it's 80% or 60%, but that's not usually the case in mantle cell. We're trying to parse the details between 10% or 15%. And in my view, I don't think any of these tests are going to tell you who should or shouldn't be treated straight away. And so at our institution, we actually watch, I would say, 90% of patients at diagnosis and try to get a sense for their disease. Okay. So that's not moving past chemotherapy. You shouldn't stand up and say don't treat patients, but that's what I just said. All right, now, the first question is, when you do decide to treat, who should have this intensive approach? And similar to multiple myeloma, there are algorithms out there, you can read them in textbooks, that tell you that the age is the primary determinant. I disagree with that. However, I would say to you that you cannot give the intensive therapy to the majority of your patients. So if you're going to consider it, it's only going to be in younger patients. All right, fine. So what happens when you give this intensive therapy? We know, or we think, that this doesn't cure patients, and we have evidence to support that. This is one example of that, and this is long-term follow-up. And I personally enjoy looking at long-term follow-up slides because it tells me what happens beyond just the typical reporting of the early data which we're used to doing. And so what does this slide show us? Well, it shows us that the overall survival is actually much, much longer than 3 to 5 years if you give intensive therapy. So this is a select group of patients. They were treated with intensive therapies of alternating therapy with CHOP-based therapy, cytarabine, which is an important drug to be used. And these are patients with intensive regimens that can live for 12 years. Now this is not, of course, overall survival doesn't just capture their first treatment, right? So this also includes the fact that subsequent therapies have improved, supportive care has improved, but nonetheless, it's an important data set. But the other thing to point out is that this does not cure the disease. And so this is a cumulative incidence of relapse. So basically over time, all probably of these patients will eventually progress. So that's an important thing to say. So the way I think about this when I'm talking to patients that are eligible is it's my view that they should always know they have an option of intensive therapy. Okay, I think that's important. And I interject my bias, which is to say I probably wouldn't do that unless you are a person who really wants to front load your toxicity, front load your intensity of therapy because you believe this period of time in which you won't need therapy is important to you. And that is going to be juxtaposed to this concept of maintenance because just like myeloma, we had this discussion with patients and then we decided to give them all maintenance after auto, right? So then they didn't have this therapy-free interval. What I think is actually a more relevant question is to ask who are the patients specifically with precision tools that should or should not get these therapies, and we are not there yet. This same group has presented, actually not published yet, these data sets that help understand maybe there's a few mutations that suggest the patients will not do well with this intensive therapy. Maybe we can use these at some day in the clinic, but we're certainly not there yet. Okay, but we will learn more about this in this era of next generation sequencing that we're in right now. Okay, now again, chemotherapy. The one thing we probably all agree with is that if you are going to give chemotherapy up front, R-CHOP is not the right choice. So this tells us that, of course, rituximab improves upon outcomes, but what I want to point out is that it's not a problem with getting remissions with R-CHOP, it's problems with keeping remissions with R-CHOP. So less than 2 years, if the overall survival is 3 to 4 years, you might think that's good. Now we think it's 7 to 10. So less than 2 years is certainly not good enough. Okay, fine. I think we would all agree with that. That's probably the only safe slide I have. All right, so then what are the options? Well, again with chemotherapy. So this is what we would now consider to be older data sets. We take this to be fact that bendamustine rituximab is more effective than R-CHOP in mantle cell lymphoma. This came out of the STILL trial, which is an indolent lymphoma trial. So this is a subset, and this is the PFS. And what we basically see is that without maintenance, you're talking about an improvement of 2-ish years to 3 years. Okay, so that's what we can say. And ultimately what that has done is this has been sort of the go-to for patients that either aren't appropriate for intensive therapies, don't want intensive therapies, but what it really means in the research world is that this has become the preferred backbone by which to test novel agents, okay? And that's kind of where we are. In fact, what I think is probably the most transformative drug in this disease, most would agree, is ibrutinib, at least targeted agent. And there's actually an ongoing trial, which is not read out yet, probably won't for a little while, that will help us understand the role of ibrutinib in the upfront setting with bendamustine rituximab. So this is a placebo-controlled trial. It is done upfront. The patients are designed to be those that are inappropriate or elect not to undergo intensive therapy. So I think it will answer a lot of questions that everybody has now. Specifically, can we safely and effectively get ibrutinib in the upfront setting? It's important to note that lenalidomide, which is also a very effective agent in the relapse setting, has been tested with bendamustine rituximab, and it looked like the toxicity was too much. Specifically, and I don't have a slide to show you, but specifically in a phase 1 setting, the hematologic toxicity was too high. There was too many infections. And so that is probably not a combination you will see or think about using. Okay, so again, my last chemotherapy slide. So, because you have to know what we're trying to move past, right? So then the question that comes up, and or at least I hear this, is, well, if bendamustine rituximab is very effective, but I still want to give intensive therapies or autologous stem cell transplant, can I combine bendamustine and auto transplant? So this is a small study led by Mass General, or Dana-Farber, sorry, and this was asking like 2 questions. One is, can bendamustine rituximab be given safely with, alternating with cytarabine? Why cytarabine? Well, cytarabine looks, if we think about chemotherapy and we look at the different regimens that have been effective, hyper-CVAD and the Nordic regimen and others, cytarabine actually looks like it's a critical drug. In other words, when you omit cytarabine, it looks like the response rates go down, it looks like the survival goes down, and you can't really give it safely at the same time with other chemotherapy, at least not at these doses. So this was an alternating strategy of bendamustine rituximab, cytarabine, prior to auto, and I think all but one of these patients got an auto. So it looks to be quite effective, all right? So 96%, and actually 3/4 of these are CRs. So that's pretty good, 23 patients. But what also happened in this study, and I think this is an emerging theme, which we will see more data on, I can tell you, is the fact that these are getting, this is a term that I don't prefer, MRD. Nonetheless, it does refer to at the end of treatment, minimal residual disease. So it subdivides CR patients, and it says not only is this regimen achieve complete response by conventional criteria, but this is with next generation sequencing assays. The majority of these patients don't have evidence of circulating tumor DNA at the time after induction. Okay, and that's the first study that I'm aware of that tested that with this assay. So we'll see more about that. And just to speak to that, and I'll talk a little bit more later, I think it's true what was said about this is not the type of test that we run out in order in our clinic today, but it does help us understand the difference between these regimens, how this might be more effective or less effective than others. I think that's an important part of research. Okay, so the third question that comes up and is becoming increasingly difficult to answer is, well, when do I stop therapy? All right, that gets at some of these concepts already debated about financial toxicity and the like. All right. So the first study to really at least make people strongly consider maintenance therapy was this one. This is a study in patients older. Actually, ironically, it says older patients with mantle cell lymphoma, even though they were right below the median. But nonetheless, it was patients over the age of 60. It had two questions. This is the second question. The first question was R-CHOP versus RFC, which we know the answer to that. R-CHOP was actually there was no difference. But this question was, can rituximab maintenance, if it's given indefinitely, improve survival compared to interferon alpha? So the way to interpret this, in my view, is unless you believe interferon alpha worsened their survival, which is possible, that rituximab, at least after R-CHOP, in maintenance and given every few months indefinitely, has an overall survival advantage over interferon alpha. Not a relevant question today, but it's the data we point to if we want to give rituximab maintenance. All right, but that's maybe not the relevant question. This is more recent, so this was at ASH. So ASH this year. So this was a question of can or should we be giving maintenance therapy after chemotherapy? And so this is a regimen here of cytarabine-based chemotherapy with rituximab, auto transplant, so they've already decided, so this is a select group of patients, and rituximab maintenance versus observation in France. They also showed an overall survival advantage to giving rituximab in this setting. And specifically what's interesting is that the survival advantage seems to be emerging with time. Now they only gave it for 3 years, so this is effectively when they basically stopped giving their treatment. And you can see these curves suggesting there's a survival advantage. Now the trouble with these data sets, other than the fact they've only been presented, is that the second therapies aren't controlled, right? So you give this therapy and then we don't know what happens down the road. And the real question in my mind with maintenance therapy is, can we just hold it and wait until later? Do we have to give it straight away? That's the same question we always have. But nonetheless, these are the data sets people have to suggest rituximab maintenance. 2 different data sets showing overall survival. Now, there's one other data set with rituximab that I think gets more at the question. And that is, can there be a test or a strategy that helps guide these decisions? So one of the criticisms, in my view, of all of these decisions of this is how I'm going to treat you up front, this is how I'm going to do after auto, is it's completely empiric. Okay? So we're making these decisions and we're basing it on large data sets, if we have them, with Kaplan-Meier curves, and we aren't having true precision medicine. Okay, fine. What this is a separate question. This came from the Nordic group, and what their question was is, can we use MRD testing, in this case it was PCR-based, to help us understand who should get rituximab? So what they did was these patients all had auto transplant, and they were followed. If they were MRD negative, they were observed. As soon as they became MRD positive, they were treated with rituximab. And the first question was, does that convert patients to MRD negativity? And the answer was yes, 87% of the time. And then they just basically kept doing that. They would give you 4 doses and then just keep giving you rituximab when you were MRD positive. Now, I don't recommend doing that, but what I find to be interesting here is 2 things. One is the time before they started progressing was quite long. The median is now at about 5 years. But if they just gave rituximab, the median was also 5 more years. So we're at 10 years now with chemotherapy and rituximab. So that's the beast that has to be tamed. That's what we need to do better than is chemotherapy. So that's the stage of thinking about novel agents. Now, the novel agents, I think we have to, there's many in mantle cell lymphoma, but the approved are basically 3, Velcade, bortezomib, lenalidomide, and ibrutinib. This is a study that is addressing these questions that I set up for you. In other words, using bendamustine rituximab as a backbone and assuming that rituximab maintenance is effective, can one improve upon that? This is a randomized phase 2 or a pick the winner design by either adding Velcade to the backbone or adding lenalidomide to the maintenance. And this hasn't read out, but this will be another data set that helps us understand, are there ways of, in this case, the question is combining chemotherapy with novel agents? And we don't know the answer yet. Or we don't know how it compares to each other. That's fair. All right. Now, in the research setting, there's still this question of how to move novel therapies up front. In the clinic, the question is, can we be using them now? novel therapies mainly being non-chemotherapy. So there's a couple data sets to point out. One is this. So this is bortezomib-based chemotherapy. Effectively what we're saying is Velcade replacing the vincristine in our CHOP. And this was presented at ASCO, it was published in the New England Journal of Medicine. And what does it show us? Well, first of all, it shows us, in this case, the PFS is not terribly impressive. If you just look at that, it certainly is better than our CHOP, but we're still talking about 2 years. I don't think that is necessarily a game changer. The curves, our eye is always drawn towards the comparison, and that's important, but the fact that it's only 2 years is, I think that's an important thing to point out. What I think is more important, and this is from a research standpoint, but I want to bring it up here, is that the complete responses were a little deeper. That's true, but what it looks to be true is that the patients that are responsive to bortezomib, they seem to, some of these patients have a very long remission. Okay, so the duration of remission actually turns out to be important. R-CHOP, the variance is low, but if you look at bortezomib-based therapy, some of these patients actually have a very long remission. The problem is we don't know how to identify them. And so it again goes back to the motif of precision medicine tools, which we don't have, which is what is it about these folks that makes them uniquely sensitive to bortezomib? If I knew what that was, this might be a regimen that I really was interested in giving a patient. Okay, so is there a regimen that you could use this week? Yes, in my view, and this is what it would be. It would be lenalidomide-based therapy. Now, a few caveats. What was this study? This was a study of 30 patients, 33, maybe 36. 36 patients, at least that were valuable. I think 38 were on the study. It started out at Cornell. And basically the concept was, let's give this to the patients that we think are not appropriate for autologous stem cell transplant. My understanding is it morphed over time to let's just give it to more patients because more patients wanted it. And this is what they observed. They observed that if you give lenalidomide with rituximab and you do that for a year at a relatively standard regimen of 20 milligrams, and then maybe you bump it up to 25 milligrams and you give them the week off and you give rituximab along with it, that you can basically assume that, and this is a small data set, but most of these patients respond. Beyond that, many of these patients actually have a complete response, which I think is very important. So now we're talking about complete remissions that look, comparing phase 2 studies is a fool's errand, but it doesn't look to be markedly worse than you might expect from intensive chemotherapy before transplant, okay? Maybe, maybe not. And the 2-year PFS were out to 85%. And most of these patients were kind of at that 2-year mark, so I think long-term follow-up will be very interesting on this study to see what the disease looks like when they relapse, how long this PFS actually will be, and nonetheless. And when they published it, it was only 30 months. That's fine. I still think this is very provocative data. Would I use this regimen in a patient today? The answer is yes. Again, I have to put myself out there. I'm not sure everyone would do that. Would I use this in every patient? No. I mean, I would have a discussion about whether this was appropriate for them or whether they were more inclined for an intensive regimen. But in my view, keep in mind I work in a place where I don't have to pay for the drugs. I think this is a reasonable approach from that standpoint. And this is probably where we are closest to something you can use chemo-free, a term I don't prefer either, today. Okay. Again, this 20-minute thing makes me rush, right? So I feel rushed, right? Anyway, so I could talk for 120 minutes about novel therapies in the relapse setting, and one message I don't want to send is that that ibrutinib is not a novel agent or not a transformative drug. I actually do believe that ibrutinib is the most transformative agent we have right now in mantle cell lymphoma. But what I think is also true is that the real story with these single agents, at least in lymphoma, and I think it's different in lymphoma than CLL, is that monotherapy will lead to resistance much quicker than in CLL. I think we've observed that in large cell lymphoma, which is what we study mostly. We're observing that in mantle cell lymphoma, and I just don't think that monotherapy itself will be the answer for the majority of these patients, except for these exceptional responders that we see. Now, that's not to say this isn't very impressive data. So what we see is when you give ibrutinib monotherapy to a relatively heavily pretreated population, most of the patients respond for some period of time. The PFS was not this high, it was maybe a year. The duration of remission, meaning those that are responding, how long does it last? It's about a year and a half. That's very impressive data for a single agent. But that's not where we're going to stop. There's other single agents that are, I'll show you one data set here that I think is important, just recently published. There's another drug that's available, of course, idelalisib, that if you look at just this, you might think the response rate is good. The problem with these targeted agents is that we don't have a great handle on the toxicity, and that's probably a drug that will not be used frequently in the clinic because of its toxicity. But what really is happening in the world of mantle cell lymphoma is the combinations, okay? This is not all the combinations being tested. These are those that I have nominated as the most important that I'm paying closest attention to, and that is the following. Ibrutinib with venetoclax, which is in early stages. They have shown small numbers of patients at ASH. The ibrutinib palbociclib, which is an effort led by Cornell. They also presented data at ASH showing that we're getting response rates in the relapse setting, maybe CRs. Now this bore out of some data also from Cornell suggesting that one of the mechanisms of resistance to ibrutinib actually can be overcome by CD4 and CDK inhibition. And in distinction to what was observed in follicular lymphoma, when you combine both of what I consider to be the most active agents with rituximab, not only was the response rate high, but the toxicity signal was less in mantle cell lymphoma. In other words, they did not observe some of the same toxicities that have been observed in follicular lymphoma. And so there's actually 2 ongoing studies with this combination, one in the United States. I think it's actually accessible at Hackensack. And this was a Nordic study. So these are the types of readouts that in my view, will probably change the way we think about treating patients in a relapse. And of course, based on what we see and observe, many of these hopefully will begin to move their way into the upfront setting. All right, what do we know about venetoclax? So we heard about this already in CLL. It's approved in that setting. Now the debate in CLL is when to use it, how to use it. It's not approved in mantle cell lymphoma, but what was observed in this study, which was multiple patients with different types of B-cell lymphoma, was that it looks like mantle cell lymphoma patients are uniquely sensitive to venetoclax, okay? So the response rate by the conventional criteria was 75%, but I think what tells a better story is this, the waterfall plot. So these patients here don't actually count for response, but most of these patients are having a reduction in their lymph nodes. There's only one exception. So the majority of patients actually, you can demonstrate biologic activity with the use of this. But the other important thing, and I think it's critical for novel agents, is what is the duration of remission? And what we're seeing here is if you just look at the observers, PRs last for a while and then they basically get lost. But this is very small numbers. But out of these 6 patients with CR to date, but it's almost 2 years in these patients, only one of them has relapsed. So at least in some patients, as a single agent, it can induce CRs that look to be somewhat durable. And those are the types of signals, from a researcher standpoint, you look at to say, well, that's very interesting, it should move forward. That is not necessarily the same way you would approach that in the clinic, but that's the way I look at that. Okay, so the last question that I would like to address, and this does not get to the specific therapies, but it gets to the way we monitor patients. The term I prefer is molecular monitoring, and the reason is that the molecules that we're monitoring can be different, okay? MRD is a time point, and you'll hear people talk about MRD monitoring, but I think it's misleading. And since the technology is evolving, I don't know that we know what the appropriate technology is. But I would submit that most of what is likeliest to happen in the way we treat lymphoma is the drugs will get better, they will improve, and we will be combining them. What is attractive about understanding molecular monitoring is this is at least potentially a tool that can be used for precision medicine that we will use independent of the therapy. In other words, it can help us understand how to make these decisions in a non-empiric way. All right, so what do I mean? So basically the concept, and what we're talking about here is circulating tumor DNA. Now there are assays that you could order this week to be used in B-cell lymphomas. But I don't recommend that. I still think this is a research tool, but this is the concept. So what we're talking about is that this is a test or an assay that can help us understand what to do with patients in multiple settings. So when we say MRD, what we're saying is here, at the end of therapy, can we subdivide patients that we think are in remission, but they're actually not? That's a useful tool. It also can be used in the monitoring setting. So it can be used to help identify relapse early. We've heard talking about that, some data set with regards to mutations in CLL. But that also can be true here, to identify relapse early, to identify clonal evolution, or as a research tool to actually understand what these resistance mechanisms are. These are research tools, at least at this point. It also could potentially be used up front. So it looks like circulating tumor DNA is a relatively good surrogate for prognosis that looks in some data sets to be independent of just typical measures of tumor burden. Now this is a very early thing to say, and it's speculative, but that's possible. And this is an area that is of intense investigation, at least at our institution, that we're looking at closely with regards to mantle cell. And then sort of this, another sort of like slide to conceptually think about it, is that the idea of precision medicine is that these tools can be used as a yes/no, but they also could be used as a what is the DNA that's circulating. We're seeing some of that in CLL with regards to resistance, but it also could be used as a tool to help us understand what therapy could be used in the relapse setting. I don't submit that that's something we can do today. What I submit is these are the types of tools that can help answer the questions of who should get maintenance, who should get transplant, when should we start therapy, when should we stop therapy. These are the questions of the future in my view. Okay, so I'm not sure if that addressed the questions you have, but there will be a chance to answer others at the panel. But in my view, the treatment strategies still require significant amounts of personalization. What I do is I discuss the intensive approach in patients under the age of basically 65. I think it's important they know that. I tend to be biased against it. I know there are ongoing studies that will use circulating tumor DNA as a tool to help understand who should and shouldn't get that, but we don't know yet. The novel agents are clearly changing the landscape. The prognosis is improving. They are still mostly in the relapse setting. They are not quite used frequently in the upfront setting, but I think that's changing. The benefit of maintenance therapy and extended duration therapy, I think we'll learn more and there'll be testing. Our institution, we actually tend to recommend against maintenance therapy, but I understand the reasons why people do use it. And liquid biopsies, molecular monitoring, these types of things, I think will help us understand these questions in a more direct, scientific, biologically rational way. Thank you.